Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, the Société Francophone de Nephrologie, Dialyse, Transplantation, and the Junge Deutsche Gesellschaft für Nephrologie, Marcus at Home welcomes Professor Didier in Brest, France, and Professor Bikdeli in Boston, Massachusetts, in order to discuss the use or non-use of antiplatelet drugs in patients with chronic coronary syndrome who are additionally receiving anticoagulation, either vitamin K antagonists or DOACs, focusing upon Dr. Didier's AQUATIC study, which was presented at the 2025 European Society of Cardiology meeting and published simultaneously in the New England Journal of Medicine. Dear Romain, dear Behnood, we are very happy to have you back at Marcus at Home after our discussion on Dr. Bikdeli's HiPro study.
Dr. Behnood Bikdeli is cardiologist and clinical researcher at Brigham and Women's Hospital, Harvard Medical School in Boston. He is main author of the HiPro study, which we discussed recently at Marcus at Home. Dr. Romain Didier is cardiologist practicing at Universitaire Hospital in Brest, France. He is a specialist in interventional cardiology and cardiovascular research. He is the leading author of the AQUATIC study, which was published in the New England Journal of Medicine and whose results were presented during the ESC. Thank you for joining Marcus at Home to talk about this important study.
Okay, so it's a great pleasure to share with you the data from AQUATIC study. So we are talking about patients with atrial fibrillation and patients needed antiplatelet therapy for stents. So in one hand, we have atrial fibrillation, needed anticoagulation. So the efficacy is for ischemic stroke from AFib. And the question is the efficacy regarding the coronary event, ischemic coronary event. In the other hand, we have the chronic coronary syndrome of patients that are stabilized or patients requiring stent for angina. So they need antiplatelet therapy. We know the efficacy regarding the coronary event and the ischemic stroke for unstable plate, for carotid, for example. But we don't know about the efficacy regarding the ischemic stroke from AFib. That's the dilemma. So the question what we try to answer is, does adding aspirin to an anticoagulant reduce the risk of ischemic event? That's the point, ischemic event in patients with chronic coronary disease requiring anticoagulation. In order to test this hypothesis, we have conducted an academic trial, randomized, double-blind, with placebo control in multi-center trial only in France. So, prior trial suggests that antiplatelet therapy increases the bleeding risk, but we don't know exactly regarding the ischemic outcome. Usually, the primary endpoint is regarding the bleeding risk, and we don't test the ischemic outcome. That's why we want to conduct this trial. This trial is open label regarding the anticoagulation. It's enroll low-risk patient for bleeding, and for the patient is not enrolled. Here we select only high-risk patient for ischemic, and the other study did not include all the patients with stents. Some study have only 15% of stents, something like that. And the other study, a FIRE, is only focusing on Asian population with specific dose of antiplatelet and anticoagulant. The design is about randomization of high-risk patients for ischemic event, and after 6 months of stent, so starting point is stent, and then we randomize between anticoagulation plus aspirin versus anticoagulation plus placebo. We have a stratification in order to include the patient already on antiaggregation and anticoagulation, and the patient are only on anticoagulation. Finally, the primary outcome is really an ischemic primary outcome about cardiovascular death, MI, strokes, systematic embolism, any coronary respiration, and acute lib ischemia. And the secondary endpoint is the bleeding. That's right, the study is very specific. What is the inclusion criteria? It's patient requiring anticoagulation and have a stent with residual high risk of ischemic events. What is this type of patient? Is patient with PCI for acute coronary syndrome or patient requiring stent for like a regular angina, but with specific criteria like diabetics, chronic kidney disease, peripheral artery disease, multivessels coronary disease, complex PCI, and history of stent thrombosis. Donc really high-risk patient for ischemic events. The main exclusion criteria is patient had very high risk of bleeding and patient with stroke also. What is the estimation of patient needed is the 2,000 patient needed regarding 24 months of follow-up. And the analysis is intention to treat and with hierarchical testing used. We have also a strata regarding the type of anticoagulation because it's open in terms of type of anticoagulation and antithrombotic treatment at the time of inclusion. The study was stopped early because an excess of all-cause mortality of one of the two groups. That's why we stopped prematurely the study at 2.2 years. That's the first point what we can learn. So finally, what we get, it's 872 patients was randomized in two groups. And finally, we have a loss of follow-up because, as you will see, the patient is a very elderly patient, very frail patient, and some patients did want to continue the study. That's why we have a slightly high loss of follow-up. What are the baseline characteristics of the patient? The patient are roughly is 72 years old, so it's not a young patient. A lot of patients with diabetic, of course. We have a patient with history of stroke, like 9% to 10%. History of AFib, this is a majority of patients that are randomized in this study. We have also patients with requiring anticoagulation for pulmonary embolism or peripheral thrombosis. And all the patients receive stents. Regarding the mechanical valve patients, it remained controversial. Not too much patient receiving mechanical valve in this case. Regarding the type of anticoagulation, the majority receive a modern treatment of anticoagulation with direct anticoagulation, and the majority was apixaban. When you look on the primary endpoint, clearly adding aspirin to an anticoagulation in this type of patient increase the risk of the primary efficacy endpoint, so increase the risk of ischemic event. Clearly, from 0 to 4 years, it clearly increase the risk. Regarding now the secondary safety outcomes, the bleeding, also adding aspirin, it's not surprising, increase the risk of bleeding. Also, you have a traduction in terms of all-cause death. Clearly, adding aspirin increase the risk of all-cause death in this population, very high-risk population. Regarding what we expect at the beginning, but adding aspirin reduce the risk of coronary event, here we didn't find any difference. That's very interesting. Here, what we expect at the beginning, we find no difference between groups in terms of MI, in terms of coronary revascularization, stent thrombosis, acute ischemia. That's why it's clearly clear, no advantage to add aspirin in this patient. So what we can get from this study? So this study increased significantly the risk of primary endpoint, ischemic outcome, increase the risk of major bleeding, and finally increase the risk of all-cause mortality. So in this very high-risk population of ischemic events, we should not add aspirin on top of anticoagulation in patients with AFib and a stent. That's clearly the answer. Thank you very much. I'm happy to discuss with you.
Thank you very much for your presentation. So, Dr. Bikdeli, we would love to hear your thoughts about AQUATIC, which you have been commented on in New England Journal of Medicine Journal Watch. So please, your comments.
Yes, thank you so much. And such an important clinical trial, and hearty congratulations to Romain and his team for this very important and much needed study. Let me start off with the first question. When I was asked weeks in advance to comment on AQUATIC, and I was excited to see the results weeks after, I was actually expecting to see an excess bleed with aspirin. So that to me was very important confirmation, but I was not entirely surprised. What I was surprised a lot about, and I would love to hear a little more from you about this, how did we come up with seeing an excess in the ischemic events? Do you think it's kind of like sequential, such that those people bled or were at risk of bleeding and they stopped everything and this happened, or there is biological plausibility? The reason I ask, some others thought it's just noise and randomness. I am not convinced about that, because if you look, a fire trial prior to yours showed the very same signal. So I think it would be a little reductionist if we put it all by chance. Love to hear your thoughts.
Thank you for the question. So I can argue two things. The first one, I believe, is one explanation is if you bleed, you can have some ischemic event. Of course, because you have functional ischemia. So you can die from that. That's the first point. The second point, as you mentioned, when you bleed, of course, you stop your treatment and you can also have a stent thrombosis. That is not necessarily recorded in our study, because if you die directly, we don't record stent thrombosis. So we don't know exactly what is the cause of death. But what we see here is an excess of mortality also for cardiovascular death. So it's clearly related to the heart. So that's my two explanations of that. So the bleeding is one major cause of ischemic event. Also, we know when we receive a patient with bleeding from everywhere, and we have a decrease of blood sample, and the patient have a stroke or a cardiac vascular event. That's my explanation.
This is so interesting and important. Thank you. Let me follow up with one more related question there, and then I have one last question. So among people who have multiple events, for example, a bleeding event and then an ischemic event, your explanation is completely satisfactory and makes perfect sense. Out of curiosity, did you happen to study or do you plan to analyze the subset of patients in your trial who never had a bleeding event? I'm curious if the same ischemic signal is there as well, because if there is, then it would counteract all the biological plausibility that we've always thought of. The more antithrombotic agents, the lower the risk. Maybe there is something in biology that we are missing. I don't know, but love to hear from you.
Yeah, I perfectly agree. So we plan a lot of sub-study also, you can imagine, so type of anticoagulation, something like that. And also patient with no bleeding, we will look at it, of course. And maybe we will find and come to you with more detail. At that time, I cannot talk about that, because it's confidential at that time. But of course, we plan to look at it. I know we could have also some conflicting between the aspirin and anticoagulation, maybe some interaction that produce this result.
Thank you so much. Now, my last question. I don't know if you followed during the American Heart Association meeting, there were also a number of interesting studies. The two that are most relevant to the theme of AQUATIC, where the randomized trials, one that tested kind of a similar strategy to AQUATIC and essentially yielded somewhat similar results, that less is more. But the one that to me was most provocative was the study called Optima AF, where the authors randomized patients after recent procedures to only a single month of dual therapy versus 12. So this was not a trial of stable patients. They had recent stuff. And even there, they found signals similar to these multiple other trials, including yours. But to me, what was concerning is numerically there was an excess in ischemic events, but I'd love to hear what you thought of that study.
Okay, so yes, I think to be honest, it's two different questions. For me, it's very stabilized patient, something like that. When you're talking, it's just after the stent, and it's also for me is something totally different. I cannot merge both studies, but we can discuss. As a physician, as a cardiologist, interventional cardiologist, I really believe that if you just study the anticoagulation or anti-aggregation treatment without taking care of what is the result of your stent, you miss something. That's my point. So we should include the result of the stent. If your angioplasty is great with good result, probably the risk of bleeding induced by the treatment will be higher than the ischemic risk. At the opposite, if your result is not optimal, the risk of stopping early your treatment, you have a stent thrombosis. The stent thrombosis, the incidence is very low, but you should manage this patient according to the result. That's my point. That's it. All this study, it's missing, for me. But for sure, intensive treatment is not so good for the patient. We should reduce.
Thank you so much for this elegant comment. And for the audience, the last thing that I would add, in the trial that I just brought up, nearly all patients received intravascular imaging for their PCI to optimize the procedure and reduce the risk of stent thrombosis. Thank you for your thoughtful comment.
So also for me, thank you for your presentation. I also have two more questions. So we see 90% from the patients used DOACs, like apixaban or rivaroxaban, but the most have apixaban. I think 62% received apixaban. So were you able to identify any differences in the subgroups with the different oral anticoagulations? I think 10% get vitamin K antagonists. Do you see any differences?
It's an excellent comment. It will be the topic of a second paper, and we will dedicate each. We will answer all of these questions, treatment by treatment. At that time, we don't have this type of detail because we should be not talk too much about that. But we will give you for sure all this answer. Because we are very, we want also to have this answer at that time.
And another question I have, I think as a young woman, I'm allowed to ask it, why are women so significantly underrepresented, not only explicitly in your study? I think it's not a problem that's in your study. It's not really common. But do you have an explanation for this?
To be honest, I don't have any answer, clear answer on that. That is for all the study in France also. They are underrepresented. For sure, we don't do any selection for men or women, so to be sure. But that's why maybe we should take care of that, and also we will look at the specific group of women in order to see if it's the same answer or so. But I not specific answer is like all the study, so maybe they are less engaged to participate. We propose less. Maybe it's for the same for all the study. I think so.
I have three remaining questions. One, particularly to AQUATIC, and then the second and third to both of you. So the first question, when looking at the Kaplan-Meier curves, most bleeding events occurred very early. And in the second half of the study, there were very few bleeding events. Do you have an explanation for that?
And to be honest, this is the question of collection of the data. Probably at the end, as I mentioned, we stop early the study, and we should ask the patient to collect all the data. That's why we have some higher incidence at some point. That's why the collection of the information, like as you can see here, we have here more patients collected with bleeding in one time. That's why we have this type of curve, you know.
And the two last questions, again, to both of you, actually. We have seen two other studies that kind of changed our understanding of antithrombotic treatment in the last months. So first came the COBRA study, presented at the ISDH, I guess, in Washington, D.C., which showed that apixaban is far safer than rivaroxaban, which has not yet been published to my best understanding. We hope that we will have the PI here also for our webinar, and we invited her, and she promised to come to us once it's published. And the second surely is the failure, actually, or the disappointing results from closure AFF, because actually we would ask you in the end, do you see that left atrial appendage occluder would be an alternative, but now we see these closure trials. So first question, do you use even more apixaban at the end of this year than you did some months ago following the COBRA studies? And secondly, where do you see the future of the occluders?
For me, currently, we use a lot of apixaban because we believe it's less gastrointestinal bleeding. When you look all the study, we find all the time this result already is not randomized at that point, but we find that. My belief is due to the pharmacological things, because it's 2 doses per day, so we have less peak of the treatment, so maybe less bleeding due to this small peak as compared to rivaroxaban. Is one hypothesis that I mentioned. That's why we prefer this treatment in these patients that are already in high risk bleed. You see on the result that all the people in France use more frequently apixaban as compared to rivaroxaban. That's one point. For the occluders, so to my point of view, at that time, I'm not so comfortable with the occluder because it's relatively invasive. It's a preventive treatment. So when you perform when procedure to treat the patient, that's okay for me. But it's in terms of prevention, if the patient dies, it's catastrophic. So, and now we have direct anticoagulant, and so the benefit of occluder is a little bit confusing. It depends of which team is performing this type of procedure. If it's low risk of procedure, they know how to do, or it's just some physicians are doing that with high risk of procedure. So it's for me, the balance is not clear. So. And you don't prevent all the stroke. You prevent only the stroke from AF, but you don't prevent stroke from vulnerable plaque that could come from the carotid as well. So you don't prevent all the stroke. So that's my
good point. Yeah. And Ben?
Yeah.
Thank you. I was benefiting from these great conversations. For the first question of comparison between apixaban and other direct oral anticoagulants, it's unfair, even though we are early, not to give shout out to Lena Castellucci and her team first. So COBRA, to me, was one of the most important trials that has been presented in a major meeting this year. And I can't wait until we see it in publication. I think the reason it's important is, to my knowledge, it's the only outcome trial that is directly compared apixaban and rivaroxaban. All of us, through network meta-analyses, etc., indirect comparisons or observational comparative effectiveness data, had a hunch that maybe apixaban is the safer of the two agents. But I think this, for the first time, is bringing the point home from a rigorous randomized trial. So that, for sure, I think is highly practice informing. But the second one is the much more challenging question. My personal perspective is, I am not completely against the technology, but the way I personally see it is more so like IVC filters for venous thrombosis, meaning it's not the to-go recommendation for me. And especially in the US, there is gross overuse of this technology, such that even people with minor bruising, etc., people who shouldn't have receive the device not infrequently receive it. And Romain is absolutely right. That device, even if it works perfectly, doesn't protect against many other forms of stroke. B, sometimes the procedural placement, etc., is not necessarily successful, such that people develop clots on the occluder, and then it's a catch-22. You've placed the device, it has caused harm, and you have to restart anticoagulation even if it's not working well. And third is the safety. Granted, there is a learning curve such that more experienced operators do it more safely. When we expand the use of it, it may end up happening with some operators with less experience, and it's not a risk-free procedure. Even some of the other so-called positive trials early this year, such as those that were reported after AFib ablation, did not include procedure-related bleeding in their main outcome results. So if I were to summarize this very complex landscape, I would say it's good to have the option, but it's not the to-go option for me unless people really don't have another option.
Thank you so much to the two of you for being our guests for 2 webinars in a row. It was really an honor to host you, and I guess the year 2025 was really rich and very important studies and new evidence for internal medicine doctors with regard to antithrombotic treatment with surely AQUATIC, HiPro, but also APCAT, Renovate, Cobra, Closure FF. So thanks again. Good night in Brittany, good day in Boston, and hopefully seeing you back here next year. Thank you.
Thank you so much.